will present on gynecologic cancer treatments. Thank you.
Hey, thank you guys for having me. I really appreciate it. This is like Friday afternoon, and usually on Friday afternoon, I'm home hanging out with my family, and I have 2 teenage girls and my wife. They never pay any attention to me. So to have all these women give me all this attention, it is a privilege, okay? So I got 20 minutes. I got to get through these slides, tell you what's really cool about GYN Onc, and I do have a little complaint. And number one is the programmers actually put me towards the end. I should have started the first one, right? Come on, we all started here, right? Think about it. You all came from that uterus. You lived there for 9 months, right? You all wouldn't be here without this organ. So next year, I want to be the first presenter, okay? Not some lung cancer guy, okay? All right. Okay, so let's get through this. So wait. Oh, here it is. Oh, here are my disclosures. I speak for companies, but I also live in California and have 3 kids in private colleges. So that's why I need to have these disclosures to fund my mortgage. Okay. All right. So I'm going to talk about GYN cancers. Okay. I'm going to talk about 3 cancers. I don't know a lot. Unlike the medical oncologists here who know a lot about all these cancers, man, I feel sorry for these guys. They have to know like 50 different drugs every year almost because of how quickly this oncology field is advancing. And you as nurses and health providers, man, you guys got to know all these drugs and their side effects so that you know what their indications are. So to know just 3 cancers and to be able to just know those and memorize those, it's pretty easy, okay? And I'm a GYN oncologist, and I trained, so I'm hesitating because my son is thinking of, going to medicine, and he's saying like, gosh, Dad, how long did it take you before you got your first job? And man, I was really depressed because I didn't get my first job at Stanford until I was 33 years old. So it took me 4 years for college, 4 years at Berkeley, and then 4 years at UCLA, and then 4 years of OBGYN. So I actually delivered babies for 4 years before I could do oncology, GYN oncology for 4 years. So that's why we get to do surgery, we get to do chemotherapy, and we get to follow these patients for surveillance and everything like that. So I've studied women for 16 years. And I have 2 teenage daughters, like I told you. I still don't understand women. They're very complex, intelligent human beings. Okay, so I'm going to tell you about what I know, okay? So what I studied over the last 16 years and also what I practiced for the last 25 years is this, okay? Endometrial cancer, big problem. Out of those 3 cancers, this is almost like, man, 2-fold, 3-fold higher than ovarian cancer. This cancer is growing 4 to 5% every year, and we don't know what to do to stop it. Ovarian cancer dropping, cervical cancer dropping, new cases are dropping. Okay? And another big problem is on the right side, you see uterine cancer is now the most lethal gynecologic cancer now, not ovarian cancer. So as of a year ago, uterine cancer became the most deadly cancer that we deal with in GYN oncology. So I'm going to talk about ovarian cancer first. This is a picture. I'm going to show you some gross anatomy pictures of surgeries that we've done. So this is a patient with bilateral ovarian masses. You can see it on both sides, like dumbbells on the right. And that little thing right in the middle there, that's the uterus peeking out at us. But this is a patient with advanced stage ovarian cancer. How do you get it? How do you get these cancers? I'm going to talk about how you get these cancers. How do you treat these cancers with all the new drugs that we have, and then also how to prevent them, okay? So here's a way that you can prevent these cancers, okay? So one, how do you get ovarian cancer? Everybody thinks genetics, right? Why do they think genetics? Because this woman here, right? She made ovarian cancer, she made BRCA famous, right? And she was on the front cover of Time magazine for that. They made it seem like she cloned the gene for ovarian cancer. No, she didn't clone the gene. Mary Claire King did. They think Mary Claire King may win the next Nobel Prize, okay? She's a University of Washington professor who trained also at Berkeley. But nonetheless, she made this gene famous because of the Angelina effect. Why? Because if you have this gene, which is, how common is it? Man, only 5% of breast cancers, only 10% of ovarian cancer patients have this gene. And when you have this gene, though, man, you have an 80% chance of getting breast cancer, and you have about a 40% chance of getting ovarian cancer. So that's why test these patients. After you test them, you do the surgery, or you do chemo prevention if you're young and you're not ready for a prophylactic or risk-reducing surgery, and then you can prevent these cancers on 10% of ovarian cancer patients. Wait, so then how do you get 90%? How do those patients get ovarian cancer? Right? This is only 10, 15%, right? So we think about this thing, it's called the incessant ovulation theory. You know what that means? That means when you ovulate too much every month, all these young ones here, you guys are every 30 days, you're hurting your ovaries. Because you got this rupture, repair, rupture, repair. Is that true? So here we go. How do these 90% get ovarian cancer? Man, who ruptures a lot of eggs? What do you guys have in Denver every morning? The Denver omelet, right? Don't you guys have Denver omelet? No? No? I had it this morning, Denver omelet. I said, I'm in Denver, man. I gotta go have some Denver omelet. You know what I mean? So anyways, so when you think about Denver omelet, right? Man, those eggs are produced like, man, chickens or hens can actually ovulate twice a day. If you keep their lights on, ask a chicken coop farmer, if you keep their lights on, you can actually make them lay 2 eggs a day, right? So do they have more ovarian cancer? Right? I'm just showing you an animal model, right? If you ovulate a lot, like hens, look at that on the left side there. You see that? The hen, they ovulate so much a year, 250 times a year, right? That's why they lay those eggs for you, for your omelets. And then you see that red? That is the risk of ovarian cancer. And then a lot of people think, like, when they think babies, they think rabbits. Like, they go, man, that dude's got a lot of, kids. They're like bunnies, or they're like rabbits. You know what I mean? You always make fun of people like that, right? But rabbits don't ovulate a lot, really. If you look, that next to humans, rabbits' ovulation is not that much. And so their cancer incidence is not as high as hen. So on the last picture I showed you on the right corner is that ovulation on that right ovary there. And that's how you get that injury repair. How do you prevent cancer if you know this is happening? How do you prevent ovulation? Well, yeah, that's the easy answer, birth control pills. The harder answer is what? You should just have a lot of babies. Have 15 to 18 babies throughout your lifetime. So then pretty much throughout your whole reproductive life, you're either pregnant, breastfeeding, and you won't get ovarian cancer. But man, that's expensive, right? Much cheaper way of doing it is just take OCPs, right? So even patients with BRCA, if you take the twins that have BRCA, the twin that actually took more birth control pills actually have a decreased risk of ovarian cancer. So even though you have a genetic disadvantage, you can use environment, you can use OCPs to change that, right? Another theory, this is big, because we think that these ovarian cancers come from really funny different places. Why? Because when you think about ovarian cancer, they get serous cancers, mucinous cancers, endometrioid cancers, clear cell cancers. Man, those cancers don't exist in the natural ovary. Wait, how do you get these cancers then? Right? Even men, right? We have testicles, they're a reproductive organ, but we don't have all those interesting cell types. At least I don't have those interesting cell types on my test, right? So how do you get these cell types? They're METs. They're metastases from the fallopian tubes. You see that picture there that I showed you? It's a seed and soil hypothesis. That means that those fimbria of the fallopian tube, they're basically dripping cancer cells on the surface of the ovary, and you end up with a big ovarian cancer, but you didn't know. Months ago, this started at the finger-like projections on the fallopian tube. So what can you do to prevent the seed and soil hypothesis? Man, you cut out the tubes when you have a chance. How? I'm having a C-section, or my wife, all right, having a C-section, and she wants her tubes ligated so she didn't have to get pregnant again. Instead of ligating her tubes, cut them out. I'm having a hysterectomy. right? For fibroids, for bleeding, whatever it is, get those tubes out. Leave your ovaries to save the ovarian function. Get those tubes out. We're beginning to see this practice adopted over the last 15 years, and we're seeing the incidence of ovarian cancer dropping already. We think it's because it's attributed to this, okay? All right. What are advances that we made in the treatment? So you could see, this is a trial, right? You got new drugs. What's a new drug that rocked our world? This class of PARP inhibitors, P-A-R-P, okay? Nobel laureates, 3 of them actually found that, hey, we have this DNA repair toolbox. And this DNA repair toolbox, when the DNA gets damaged, our cells are really smart. Cancer cells are really smart. When that DNA gets damaged like this, they recruit these enzymes called PARP, PARP enzymes, and they basically go and they seal up that broken DNA. And so this is Nobel laureate that actually figured this out. And then the cancer biologist said, well, wait, if the cancer cells depend on these cells or depends on these enzymes or these repair trucks to go repair the DNA on that DNA railroad, man, block it. PARP inhibitors. And these PARP inhibitors have rocked our world in the sense that they not only delayed remission, look at this. Man, you delay remission with this PARP drug, Lynparza, combined with Avastin in the majority of ovarian cancer patients. You can delay it from, 15, 16 months to almost 4 or 5 years. Man, that's huge. That's huge in ovarian cancer. And ultimately, they basically show that you can improve overall survival by a year, despite the fact that a lot of the patients who got placebo ended up crossing over to get the real drug when they got the placebo first, right? They're able to improve their survival like this, right? So these are the PARP that you could get approved for upfront treatment. If you have BRCA, all you have to do is take the PARP by itself. You don't have BRCA, but you have HRD or HR deficient. You can take that drug, Lynparza with Bev or niraparib. That's approved now. All right, so that's ovarian cancer, okay? Questions? I'm gonna go through the next 2 cancers, and we're done, okay? Ready? This is a uterine cancer. This is one I told you about. There's a lot of problems, okay? So this is a uterus. So if you cut this open, you can see that top part there is what? And what is the right side there? Who hangs out in the OR with us? Any OR nurses here? Yeah, so when you're in the OR, we usually cut these things open. You can see blood clots. So you got a 70-year-old lady who's postmenopausally bleeding. Man, they'll come to the doctor, right? Unlike ovarian cancer, that organ is hidden within, and you can't find the cancer really easily in an early. This, you find most of them early. 80, 90% of the time, you can capture these cancers early because of the fact that these patients bleed after menopause. Got it? And that's a blood clot that you see there, and that little friable popcorn thingies, they look like they're uterine cancer. So here, on the left side here, you see, look at the uterine cancer on the left. It's about 30,000, and then 5% of all cancers. And then on the top there, you see uterine cancer causing the death associated with this. So that means that increase from 30,000 on the top there, you see 69,000. So in 1990s, it was 30,000. Today, it is 69,120. See that, uterine cancer? Man, that doubled, right? That's huge. So I still remember I gave a talk at the University of Colorado, and I was introduced by one of the junior fellows. And he introduced me. He goes, yeah, Dr. Chan, he trained in the late 1900s. I did. I graduated from med school in 1995, exactly where I put that there. Should have punched him. Anyways, so my cancer has almost doubled, right? How did that happen? What's causing this? We think it could be obesity. That could be contributing to this. And you see the uterine cancer, like 3% before. It was under ovarian cancer 10 years ago. And now, just as of last year, it surpassed ovarian cancer as the cancer that causes the most number of deaths per year. Got it? Problem, right? How do we fix this? Man, we have better surgeries for them, right? We have robotic surgery systems to get more precise procedures on this. And this is important because as we operate, there's always fine tremors, right? So surgeons that use this robotic surgery, they actually can decrease their tremor. So every time that robot moves 1 inch, when you move that console 1 inch, you can scale that robot to only move 1/2 inch. Do you get it? So then the fine little tremors that you have in your hand are no longer available because this is a really good system. We have patients, right, that ask me that. I still remember a couple of years ago, one of the elderly patients was just messing with me. So right before surgery, she goes, Dr. Chan, I'm going to have surgery with you soon. I go, yes, we're going to take you back in about an hour. And she goes, did you get enough rest last night? I go, yeah, I did. Did you have breakfast? I go, yeah, I did. Did you have coffee? I go, yeah, I did. Did you have too much coffee? Come on. So then I said, no, I don't. She goes, let me see your hands. Okay, fine. So I stick my hands out like this, right? And then right before she goes to sleep under anesthesia, I whisper in her ear, but ma'am, this is the hand I operate with. I'm joking, I don't do that. That's why you shouldn't look me up on Yelp, okay? I don't have very good Yelp scores because of that, okay? I'm just kidding, all right. So what are drugs that actually change the way we care for patients, right? Here are the drugs, man, look at this. Just the last 4 or 5 years, we got all these drugs approved. These are the paradigm shifts that I'm talking to you about, right? From the left-hand side here, adding Lenvima to the drugs, right? On the middle side here, adding dostarlimab. That changed our survival of uterine cancer patients. And then in 2024, that checkpoint inhibitor came up front. So every patient with advanced stage uterine cancer can get a checkpoint inhibitor, pembrolizumab, dostarlimab, and durvalumab. But there's only one of these checkpoint inhibitors that actually has been proven to improve overall survival in advanced stage and recurrent uterine cancer. And you can see on the left side here, man, we finally have something that can help these patients with this disease that is causing more deaths every year now compared to ovarian cancer. And this is one of the drugs that ultimately showed overall survival benefit, just like Lynparza did, or Olaparib showed for ovarian cancer. Here you see the dostarlimab drug improving overall survival for advanced stage and recurrent endometrial cancer patients. All right, 3 more minutes. Ready? Cervical cancer. All right, so here's typical cancer. Uterus on top, tubes and ovaries on there, and you can see right on the bottom there, right around 11 o'clock to 4 o'clock of that cervix, that's all cancer there. The left part there is all normal. That is the cancer that we did a radical surgery to remove to offer some cure on these patients. Another Nobel Prize. Okay, I'm going to talk to you about 2 more Nobel Prizes. Dr. Papanicolaou found the pap smear. He didn't win the Nobel Prize, but Dr. Zerhausen actually found that the virus is what caused this cancer. Man, it's an infectious disease. We didn't know that. We just knew back then when I was going to school is that, man, nuns don't get cervical cancer. Prostitutes, sex workers tend to get more. Why? Well, it's probably sexually transmitted. Wait, is it the herpes virus? Is it the gonorrhea? Is it chlamydia? He isolated the DNA from the human papillomavirus. Not only did he isolate and found that there's only one type, but there are many, many types. And because of that, you can screen for this virus on top of the pap smear with Dr. Papanicolaou, and more importantly, you could do what? Yeah, you can eradicate this, right, by preventing this. So HPV vaccination uptake. This is happening, right? You see that, all the green here? There's significantly countries that introduce, in Europe, 77%, in the United States, up to 90%. This vaccine came out in 2006. I was a junior faculty at that time at Stanford, and then the local paper, San Francisco Chronicle, interviewed me. And they go, what do you think about this vaccine? Came out in New England Journal of Medicine. Merck came out with this first vaccine. I said, man, I hope, since I'm in my 30s, by the end of my career in my 60s, right, 20, 30 years of a career, I hope never to see cervical cancer again, right? After I said that, 30 minutes later, guess what happened? I got hate mail in my Stanford email box. From who? religious rights groups, right? They're saying, what are you doing to our young girls? What you just said on that paper is going to promote early sexual promiscuity, right? I get it. That vaccine, when it was first introduced, it was approved for 9-year-olds, right? And I have 2 young girls. So at 8.5, I'm thinking, wow, I got to start vaccinating them next month because they're going to have sex when they're 9.5 years old. Oh, that just kills me as an Asian dad. You know what I mean? So fortunately, when both my young daughters, before they got vaccinated, they said, Dad, don't worry, we're not going to have sex until you're dead. So my best friend says, he goes, dude, you're going to die early. You better get somebody to taste your food tonight. No, I'm joking. I vaccinated all 3 of my kids, my boy and my girls, right? If you think about it, the vaccine person actually said this. Dr. Zerhausen said this. He goes, it's better to vaccinate the boys. Why? Why is it better to vaccinate the boys? Like if you only had $1 to vaccinate, man, vaccinate the boys. Don't vaccinate the girls, right? Should vaccinate everybody. Why? Because the boys are the vectors, man, right? We transmit it, right? And we have more, or do we? Do we have more lifetime sexual partners than girls? Is that true? Huh? Yeah? No? So they've surveyed people, 15,000 people. Look this up in Journal of Sexually Transmitted Diseases. They surveyed 15,000 sexually active reproductive. They go, how many lifetime sexuals have you had? And they compare the boys to the girls or the men to the women. How many lifetime sexual partners do men have? About 14. And then the girls have about 6 or 7. So they have half. Man, that doesn't make sense, does it? I mean, if you divide this room up right here, right? And you got half boys here and half girls here. And we lock those doors for 20 years, right? And see what happens. And then we let you all out. And we're going to ask, hey, how many lifetime sexual partners do you have? Right? Wait, how did the boys that come out of here have twice? They're liars, man. They lie. And the girls lie too, but the other way, right? Anyways, all right, I got to go on. All right, so we prevented this, all right? So vaccine is FDA approved for 11 years old. But you could start as young as age of 9. Now, we push the vaccine up to 45, okay? So if you're under 45, you can actually get this vaccine and get it covered. The last Nobel Prize laureate is these guys who invented the checkpoint. I talked a little bit about the starlimab and how it's an immune checkpoint inhibitor. All this came from these 2 Nobel laureates. Dr. Allison is from MD Anderson, and Dr. Hanjo is from UCSF. He was a faculty there for a few years, and they basically found this checkpoint inhibitor. How? And these checkpoint inhibitors rocked our world. Look at this. Adding checkpoint to cervical cancer in the middle there, pembrolizumab, and even adding antibody drug conjugates. There's a tisotumab or Tivdak drug that is also FDA approved for recurrent cervical cancer that have improved overall survival. So not only do we have checkpoint inhibitor immunotherapies, we have antibody drug conjugates, which is another Nobel Prize by Dr. Carolyn Bertozzi from Stanford at 2022 or something like that. And she found this antibody drug conjugate basically clicking these 2 biologic compounds together. Immune checkpoint inhibitors basically can eat up our cancer because we're waking up these T cells to go attack against the cancer. And now look at all these drugs I can use for cervical cancer, from immune checkpoint inhibitors for advanced stage disease to looking at antibody drug conjugates with Tivdak, and also antibody drug conjugates with in HER2 against HER2 to attack against our cancers. What did I cover? Covered uterine, ovarian, and cervical cancer. Talked about how you get these cancers, from viruses to ovulation to genes. We talked about how uterine cancer has become a bigger problem for us compared to ovarian cancer. But fortunately, we have new drugs. Nobel laureate research led to PARP inhibitors, led to immune checkpoint inhibitors, antibody drug conjugates that have able to improve the survival of our patients, but more importantly, prevent, right? Screen these cervical cancer patients, prevent ovarian cancer by taking tubes out, by checking for BRCA, and also decrease obesity so we have less incidence of uterine cancer. Thank you so much for having me. Hey, I want to thank Sarah for inviting me. She met me about a year ago. She goes, "What are you going to do next year in..." I don't know. I don't even know what I'm doing next week. And then I promised her I come over here, and I really have been able to enjoy your beautiful city. I went to your gardens. I went to eat Denver omelets and everything like that. And I may go try out that Buckhorn Exchange tonight, okay? Go try some game foods. Thanks so much, Sarah, for having me. Appreciate it.